Welcome to the University of Michigan Dentistry Podcast Series, promoting oral health care worldwide.
The rotational path of insertion differs substantially from the conventional approach in that one segment of the partial denture is seated first, then the remainder of the prosthesis is rotated into position. Its great advantages are the elimination of clasps to improve aesthetics and reduction of tooth coverage to minimize plaque accumulation. Part 1 in this two-part series of films will consider the use of the rotational path concept in the maxillary class 4 partially edentulous arch. Part 2 will describe its use in the maxillary and mandibular class 3 partially edentulous arches. These are the three most common situations in which it may be most effectively utilized. At the end of the two films, the viewer will be able to describe the rationale and indications for the use of the rotational path of insertion and identify its advantages and disadvantages. The most obvious advantage of the rotational path concept lies in minimizing the use of conventional clasps. The direct retainer requirements are satisfied through the incorporation of a rigid retentive component in conjunction with a specially designed rest. The rigid component rotates into an undercut and is maintained in intimate contact with the tooth surface. The specially designed rest prevents migration of the tooth in function. The effectiveness of the rigid retentive component is dependent upon the conventional clasping utilized in the design. When the partial denture is in place, the rigid retainer remains passive, since no flexible component exists. The mechanics of the Class 4 rotational path can be illustrated in this series of diagrams. The anterior segment of the framework is seated first by placing the rigid minor connectors at the depth of the proximal undercuts. Point A then becomes the approximate center of rotation as the framework is rotated into its final position. Point B is the retentive undercut located on the distobuccal surface of the posterior abutment. B' indicates the arc that the cuspid minor connector would have to follow to be displaced, assuming effective posterior retention. It becomes apparent that the anterior segment cannot be dislodged without first releasing the clasp on the molar. When surveying a Class 4 cast for a rotational path of insertion, the cast is mounted with the occlusal plane parallel to the base of the surveyor. The goal is to locate undercuts on the mesial surfaces of the anterior abutments for the rigid retentive elements and buccal undercuts posteriorly for the conventional clasp retainers. As demonstrated, both cuspids have adequate undercuts mesially, and both second molars appear to have sufficient undercuts on their distobuccal surfaces. After this has been accomplished, the surveying table is again moved so that the analyzing rod is in contact with the mesial surface of the cuspid as before. The cast is tilted until no more space exists between the analyzing rod and the mesial surface of the cuspid. The analyzing rod is then used to determine whether the rest of the partial denture will be able to seat in the rest preparation without interference. The same procedure is carried out on the opposite cuspid. It is apparent on this cast that no interference will exist. The reason for surveying the anterior segment in this manner is to determine if the partial denture can be seated anteriorly along the path represented by the analyzing rod. The molar teeth, however, are surveyed with the analyzing rod perpendicular to the occlusal plane, since the retentive clasp will function in a conventional manner. Following the surveying procedure, the design of the framework is drawn on the diagnostic cast. An anterior strap major connector is selected, since this is an all-tooth-borne appliance and rigidity is not critical. The minor connectors along the mesial surface of the cuspids will engage the undercut as previously determined. Notice that a long cingulum rest is used. After correct preparation of the cingulum area of the cuspid, this rest with its minor connector will ensure retention and prevent migration of the cuspid labially out of the appliance. Circumferential clasps engaging distobuccal undercuts on the molar teeth are selected. The usual type of occlusal rest preparation with adequate depth will be made on the second molars in the mesial fossa. Notice that the major connector is designed to be at least 6 millimeters away from the gingival margins of the posterior teeth. After the appropriate mouth preparations have been accomplished, a master cast is recovered from a suitable impression. Conventional occlusal rests have been prepared on the maxillary second molars. Also, rests have been prepared on the maxillary cuspids, extending across the entire cingulum area. The cingulum rest preparations must be positive so that the appliance will not be able to move tissueward and the cuspid will not be able to escape the appliance. In addition, the vertical walls of the rests will provide a bracing component to the partial denture framework. If dentin has been penetrated, then a suitable restoration of amalgam, composite, or cast metal must be used. Beads are scraped along the master cast to accommodate the edges of the major connector. The scraping of the cast by the dentist will ensure the desired outline of the major connector when it is fabricated in the laboratory and will provide positive contact between the edges of the major connector and underlying soft tissue. However, such scraping of the cast must never be carried out across gingival tissue. The nature of the anterior base is determined by the degree of horizontal and vertical overlap of the anterior teeth. When the vertical overlap is severe and there is danger of breaking the anterior base, then an all-cast base should be selected. When this is done, the teeth must be set by the dentist and an index sent along to the laboratory so that the teeth can be replaced in position as determined by the dentist. The completed cast partial denture is now being seated on the cast. Notice that the anterior segment is positioned first. Then the molar clasps are rotated into place. Such a partial denture with an all-cast anterior segment will generally prevent breakage of the teeth or the plastic base. The minor connector coming off of the cuspid rest swings away from the tooth to expose as much gingival tissue as possible. As the major connector extends posteriorly, it remains more than 6 millimeters away from the gingival tissues. For this patient, the determination was made to simply butt the teeth against the labial surface of the anterior ridge without the use of an acrylic flange. An intraoral view of the patient clearly indicates the limited space between the crest of the maxillary anterior ridge and the incisal edges of the lower anterior teeth. It is apparent that the mandibular incisors have extruded due to the lack of contact. The indication for the use of an all-metal base now becomes more obvious. While viewing the patient with the completed denture in place, the advantages of such a design can be presented. These include improved aesthetics, since the anterior clasps are eliminated, minimal tooth preparation as compared to that which would be necessary for a fixed restoration, minimal tooth coverage, ease of oral hygiene maintenance, since the appliance is removable, and a reduced chance of distortion, since the retentive components are rigid. However, certain disadvantages must also be pointed out. No adjustment of the rigid retentive component is possible. There is little tolerance for error in the casting. Well-prepared occlusal and cingulum rests are essential, and some patients may object to wearing a removable appliance. The rotational path concept in removable partial denture design is effective in meeting the aesthetic and functional demands in the prosthetic replacement of maxillary anterior teeth. The rationale, indications, advantages, and disadvantages of this concept have been presented. Part 1 in this series of films described the use of the rotational path of insertion in the replacement of maxillary anterior teeth. This second part will illustrate its use in the replacement of maxillary and mandibular posterior teeth. This cast demonstrates a common design problem which may be solved with the rotational path concept. Long-term missing posterior teeth have resulted in severe mesial tipping of the distal abutments. Conventional clasping of such abutments is often difficult or impossible to accomplish without compromising basic clasp design principles. However, the undercut on the mesial surface of the molar tooth may be effectively utilized for retention by designing a rotational path type removable partial denture. As indicated in this illustration, the rotational path framework is designed with a long occlusal rest on the molar abutment with a rigid minor connector, which will be rotated into the mesial undercut. The anterior retainer is a conventional clasp. Point A is the distal-most portion of the occlusal rest and represents the center of rotation as the framework is seated. A' represents the arc of rotation, which the minor connector E will follow as it is rotated into position. Area B, then, is the space which must be blocked out in order that the minor connector may be seated without interference. With the framework fully seated, the rigid minor connector D is held firmly in place by the anterior clasp. Arc C' represents the path that the minor connector would follow if the framework was rotated about the retentive tip of the anterior clasp. It becomes apparent then that in order to remove the framework, the anterior clasp must be disengaged first. An occlusal view of the cast shown previously illustrates the 4 rest preparations necessary in this situation. These include the usual occlusal rests on the distal of the anterior abutments and the long occlusal rests on the molar teeth. Both molars will contain the long rest with its minor connector in the undercut, and both premolars will be clasped conventionally. The specially designed long occlusal rest is necessary in order that the retentive assembly made up of the rest and minor connector will meet the basic requirements of clasp assembly design, that is, support, bracing, encirclement, retention, and passivity. Reciprocation is not necessary since there is no flexible component. Instead of the usual surveying method, a divider is employed to determine if the undercut on the molar abutment is usable. One point of the divider is placed in a small hole which coincides with the distal most end of the long occlusal rest, and the other point is placed at the depth of the undercut. The divider is then rotated upward. If the tip of the divider strikes the tooth and cannot escape, the severity of the undercut must be reduced until the divider can be freely rotated upward as illustrated. Retaining the same rotational point, the divider is extended to make contact with the distal marginal ridge of the first premolar. Moving the arm in a cervical direction will indicate the amount of blockout that will be necessary. The blockout must follow the curved path of the divider as it moves downward from the marginal ridge. When seating the completed framework, the distal most ends of the molar rests are placed in position first. Then the clasps on the anterior abutments are seated. Notice that the inferior portion of the anterior minor connectors will follow a curved path, which is dictated by the posterior rotational centers. Therefore, the blockout in this area must be accomplished as described in order that the framework can be seated without interference. The minor connector on the molar abutment is in intimate contact with the mesial surface. Consequently, the molar rest cannot be lifted because the minor connector is locked into the undercut. The framework can only be removed by first dislodging the clasps on the premolars. Viewing the completed framework on the master cast, it is important to remember that the minimum thickness of the rests should be at least 1.5 millimeters. This is especially important where the rest joins the minor connector. If the marginal ridge has been inadequately reduced, then the danger of fracture at the junction of the rest and the minor connector is greatly increased. A close-up view of the retentive assembly on the mandibular right molar shows the minor connector engaging the undercut. The thickness of the minor connector in this instance is somewhat excessive and should be reduced. Notice that a slight space exists between the bottom of the minor connector and the underlying tissues. The gingival aspect of the minor connector should always be relieved lightly so that its base will not impinge upon the free gingival margin. The mandibular posterior rotational path partial denture can be demonstrated clinically on this patient. Notice the long occlusal rest preparations on both molar abutments. Both posterior abutment teeth are tipped slightly forward, and sufficient undercut exists on their mesial surfaces for adequate retention. When seating the partial denture, the molar rests are placed first, and then the premolar clasps are rotated into position. The advantages of this type of partial denture design become apparent in this patient. Each molar abutment is free of clasp arms, and if the rest preparation is adequate, the occlusal rest with its minor connector will provide all the basic requirements of a clasp assembly. Other advantages include minimal tooth coverage, ease of oral hygiene maintenance since the appliance is removable, minimal tooth preparation, and a reduced chance of distortion since the posterior retentive components are rigid. However, there are certain disadvantages. These include no adjustability of the rigid retentive component, little tolerance for error in the casting. Well-prepared occlusal and cingulum rests are essential, and the potential that some patients may object to a removable appliance. Replacement of maxillary posterior teeth with a rotational path denture is accomplished in a similar manner, except that the framework will follow an antero-posterior rotational path of insertion. Point A is the anterior-most point of the long occlusal rest and is the center of rotation as the framework is rotated into position. A prime is the arc of rotation, which the minor connector of the posterior clasp assembly will follow during seating. The letter B represents the space which must be blocked out in order that the minor connector can be seated without interference. Once the framework is fully seated, displacement of the anterior minor connector would have to occur along arc C prime, when the center of rotation is the retentive tip of the molar clasp. It is evident then that the anterior minor connector and rest cannot be dislodged without first releasing the molar clasps. This cast illustrates the rest preparations necessary for the maxillary or antero-posterior rotational path of insertion. Long positive rests have been prepared on the anterior abutments, while the posterior abutments have been prepared to receive conventional clasp assemblies. The most obvious advantage to this application of the rotational path concept is the elimination of buccal or labial clasps on the anterior abutments, resulting in an aesthetically pleasing as well as functional prosthesis. The other advantages described previously are also valid in this situation. The application of the rotational path concept in the design of maxillary and mandibular Class 3 removable partial dentures has been described. With a sound grasp of the rotational path concept, the dentist will be capable of designing a great variety of partial dentures which utilize the advantages that the rotational path affords.
You've been listening to a presentation from the University of Michigan School of Dentistry, which is dedicated to supporting open learning and open educational resources. This recording is licensed under the Creative Commons. It may be reused and redistributed for nonprofit use. Please attribute materials to the University of Michigan School of Dentistry and redistribute under this same license. For more information on how this and other University of Michigan School of Dentistry recordings may be used, visit www.dent.umich.edu/license.